Sialendoscopy, which is a minimally invasive procedure where you take a small endoscope that is roughly about 1 millimeter in diameter. So first picture that. The camera, a light source, it's 1 millimeter in size, and it allows you to endoscopically evaluate the ducts of the parotid gland and the submandibular gland, which are our major glands in our head and neck. It's similar to like a colonoscopy or an upper endoscopy, but just up the glands. And so I tell patients, imagine like I'm a termite going in the trunk of a tree, and I'm going to go up and I'm going to arborize and I'm going to see what's happening on the inside, what's going on with the plumbing. About 11 years ago, I had a patient who came in who was having salivary gland dysfunction. I had trained in residency to do salivary endoscopy, and there was only probably a few centers in the late 90s, early 2000s who had anybody who did salivary endoscopy. And I had a former boss that had trained with the greats over in Germany and France. And so I had learned the technique, and so I looked at this patient and said, I think I can help you. And so I talked to the reps, they brought in the equipment, and I offered her salivary endoscopy and dramatically improved her symptoms. And it was one of the most amazing things because I don't think I ever gave a lecture on it at that point. I didn't publicize anything. And the next thing you know, word got out and spread like wildfire, whether it was social media, I don't know, that I became the salivary guy for North Carolina. And so now I see people from all of North Carolina, South Carolina, Virginia, Tennessee, and it's because I built this skill set over time of offering salivary endoscopy. There are people, I think, who have started to kind of figure out, hey, can I do this as well? Because it's not a technically challenging technique in and of itself, but understanding patient selection, understanding how to do it is difficult. But then what really probably vaulted us was that I took this endoscopy that is typically done everywhere in the US in the OR. And I do it, mine, probably 75% of the procedures awake in clinic. And I do that because, to me, it's a minimally invasive procedure. It's not very uncomfortable or painful. And so I started asking the question of cost effectiveness. Is it really cost effective for me to be using my operative time to do an endoscopy that may take 30 to 60 minutes? Is it really cost effective for that patient to have anesthesia, an anesthesia bill, a longer OR time, a pre-op, a recovery, and literally be at the hospital for 4 to 5 hours for what essentially is a 30-minute procedure? Does it make sense for them to have a driver that then has to also take a day off of work and then come in to take them home? Now they can eat breakfast, they can eat lunch, they can drive themselves to clinic, they can be awake. I can show them what's happening in their duct. I can give them biofeedback so that their family member is not trying to translate what he said he did to them 3 hours later. And so I think what really put us on the map is that we are one of only 2 places in the entire country where we do a high volume of endoscopy awake to manage these conditions. And I think practitioners, when I give talks locally, regionally, nationally, and internationally, are always shocked that I'm able to do this. And it is funny, and I think about, well, how many people go in for a colonoscopy and an EGD and all these things? We don't do typically general for that. And so that's sort of really what vaulted us, is that it became then known that if you have a challenging case, go see Hackman, and guess what? You might be able to do it in the clinic and go home the same day.